Good evening, everyone. I am Ruth Price Rollins. As president, I bring you greetings from the Greater Cleveland Alumni Chapter of Delta Sigma Theta Sorority Incorporated. I am so glad that you all have decided to join us and our wonderful Physical and Mental Health Committee in bringing this much needed information on diabetes. Have a very good evening. I hope that you, like myself, will learn something. It is a pleasure to have you, and please enjoy. Thank you for being here.
Hi, good evening and welcome everyone. November is National Diabetes Awareness Month, so we are pleased to offer this important webinar and to have our special guest speaker share her expertise with us. After the event, you will be emailed an evaluation. We appreciate if you take time to complete it. And without further ado, we will begin our program. My name is Kalia Fisher-Grace, and I'm the chair of our Physical and Mental Health Committee. And I have the great pleasure to introduce our speaker, Dr. Julia Blanchette. Julia was diagnosed with type 1 diabetes over 20 years ago when she was 7 years old. She has proudly been wearing an insulin pump since the year she was diagnosed and has a special interest in do-it-yourself diabetes technology. She currently works as the diabetes care and education specialist, insulin pump, and continuous glucose monitor trainer at the Cleveland Clinic Diabetes Center. She recently finished her PhD in nursing science at Case Western Reserve University and is a postdoctoral fellow in integrated diabetes management at the University of Utah. Her research is focused on the transition from pediatric to adult diabetes care, diabetes self-management programs, and financial stress, mental health, and self-management outcomes in young adults with type 1 diabetes. She has given numerous presentations and she has many publications on diabetes technology and on her research. She also serves as the co-chair of the Pediatric and Camp Community Interests for the American Association for Diabetes Educators and on the board of directors for the Juvenile Diabetes Research Foundation, Northeast Ohio. In her spare time, she is heavily involved in the Northeast Ohio type 1 diabetes community. She also enjoys helping with Camp Homeda Coda, where she is the healthcare director. She enjoys exploring Cleveland and writing. Without further ado, I'll turn it over to Dr. Blanchette.
Thank you so much for the introduction. I am so honored and excited to be here tonight to get to talk to this group of women about diabetes. So I'm mainly going to be focusing on how to diagnose diabetes and then the signs and symptoms of misdiagnoses. And I'm going to share some stories with you guys about what it's like to be misdiagnosed as well. So I kind of wanted to start with telling you a little bit about me. That already happened a few minutes ago, but I'll kind of just talk about how I got involved in the diabetes community so you guys have a little more background on that. So I've lived with type 1 diabetes for over 20 years, and my family actually became very involved in our local diabetes community when I was growing up in Connecticut. And I used to be really shy and uncomfortable about having diabetes. And I went to a diabetes camp in Massachusetts growing up that changed my life and helped me become the confident person I am today and helped me embrace living with diabetes. So that's kind of how I ended up going into the diabetes education field. And then in nursing school, I discovered research. So now I love both, and now I'm doing both. I also have a strong interest in diabetes technology. In case anyone ever has any diabetes technology questions, I don't know how familiar you guys are with diabetes, but we're not going to get into that today. If you have questions about tech or anything, we can do that at the end. And then I also wanted to let you know, so my dad was recently diagnosed with type 2 diabetes, and I am his primary caregiver. So I also have that insight as well. And then I work with people of all ages with all types of diabetes. So I'm here to share those experiences with you. So just to give you guys an overview, I know some of you are medical professionals, but I don't know everyone's background. In general, diabetes is a condition in which the body cannot produce insulin, or it cannot use it in the right way. And it results in an abnormal metabolism of carbohydrates and elevated glucose levels in the blood and urine. So diabetes is pretty common. I'm sure all of you are impacted in some way or know someone with diabetes. Over 10% of the population has diabetes, which is in the US, sorry, which is about 34.2 million. And unfortunately, over 7 million are thought to be undiagnosed. These statistics are from 2018 from the American Diabetes Association. These are the most recent statistics on thought to be undiagnosed population. So when you're diagnosed with diabetes, you're not diagnosed with the type of diabetes until after you have an actual diabetes diagnosis. So here are the criteria to diagnose diabetes, which is dysregulation of glucose, or that metabolic state where you're unable to process that glucose. So a fasting blood glucose, so fasting is when you don't eat for 8 or more hours, of 126 or greater. Any random finger stick glucose check of 200 or higher. So that's if you've eaten at all in the past 8 hours. And then there's something called an oral glucose tolerance test, which is used to diagnose diabetes in adults. And if the 2-hour value is over 200 or over, that would be a diagnosis. And then if you have lab work done, a lot of people will get annual A1C, which is the average blood glucose over a 3-month period. So this percentage translates into an average glucose number. So if anyone has an A1C of 6.5 or greater, that's also considered a diabetes diagnosis. So this is really important. I want to go over the signs of diabetes. I think a lot of us know them, but as part of reducing misdiagnoses, this is really important to go over. So thirst, frequent urination, blurred vision, unexpected and unexplained weight loss, fatigue that won't go away, or like tiredness that won't go away, and hunger are the common symptoms. And these can be symptoms of type 1 or type 2 diabetes. If it's quick onset, if everything happens suddenly, in particular the weight loss, that's usually indicative of type 1 diabetes, but it could be either. And we'll get into the types in a minute. But there's a couple other symptoms specific to adults with type 2 diabetes, and those include wounds that aren't healing and tingling in the hands and feet. And the reason why those are specific to adults with type 2 diabetes is because a lot of times those are some vascular complications that present at diagnosis. And we'll get a little more into that in a bit as well. So I also wanted to pitch the dangerous signs of diabetes here for you. So the fruity breath smell, that is a really dangerous sign of diabetes. That means that your body is producing acetone and that your body is out of energy sources. So you're unable to use any of that glucose in your bloodstream as energy. So you're basically using other sources of energy, which results in this acid buildup. And that's why the breath smells fruity. So if you ever see that symptom, this can happen to people with diabetes as well, but it's usually an undiagnosed type 1 diabetes. That is definitely a sign to get medical attention. When one can't breathe or has trouble breathing, that can also be a sign of diabetes. So I've actually had a few patients recently that thought they had COVID, and it turned out they had undiagnosed diabetes. So like the one couldn't breathe, so he assumed he had COVID, and he was in diabetes ketoacidosis, or DKA, which is that really dangerous state when your body releases that, it's basically releasing an acid product as another source of energy. And then any abdominal pain and vomiting, in addition to the other symptoms or signs of diabetes, is also very dangerous and would warrant immediate medical attention. So right here, we're going to focus on the difference between type 1 and type 2 diabetes, since those are the most common types. And this here is a picture that diabetes care and education specialists love. So we love showing people this diagram here. So on the left, you see that there's these little blue dots in the bloodstream. So the blue dots are glucose, and then there's no insulin in there. So because there's no insulin, the glucose gets stuck and the cells can't use that glucose as energy at all because there's no insulin. So then on the right, we have type 2 diabetes. So the pathophysiology is a little bit different. So you have the yellow insulin, the yellow dots are insulin. The insulin opens up the cells so that you can use the glucose as energy. However, for some reason with type 2 diabetes, the insulin isn't unlocking the cells the right way. So you have the yellow dots or that insulin in your bloodstream, but you also have the glucose stuck in your bloodstream, and it's also not used the right way as energy by your cells. But that being said, there's all of these different types of diabetes. So type 1 and type 2 are the most common, but one I'm also going to highlight today is called LADA. LADA is a latent autoimmune destruction of the beta cells. So basically what that means is it's an autoimmune diabetes, like type 1 diabetes, where your body attacks your own pancreatic beta cells and you can't produce insulin anymore. But with LADA, it's a very slow deterioration and it occurs in adulthood. So often that goes undiagnosed or it's misdiagnosed. And so we'll get into that in a little bit. Another really interesting form of diabetes is called MODY or monogenic diabetes. And with MODY, often you need to take insulin, but not always. And if it's not diagnosed appropriately and the treatment plan doesn't match up with the actual type of diabetes, you may not be helping the person with diabetes in the best way. And then there's gestational diabetes as well. There's, which, gestational diabetes is an insulin resistance just during the later part of pregnancy. And then there's a couple other genetic syndromes like Wolfram syndrome, which cause kind of beta cells that aren't producing insulin in a way that works to unlock the cells. So it's kind of like an insulin resistance, but it's genetic, like strictly genetic condition. And then there's also cystic fibrosis related diabetes where the pancreatic ducts and the pancreas become clogged with mucus, like a lot of the organs do with cystic fibrosis, and you become insulin resistant because of that. There's also other forms of diabetes where if you have damage to the pancreas or have a pancreectomy, which you actually see that a lot with adults, not a lot, but like a lot more than I thought I would see it. That's another cause of diabetes, so completely removing the pancreas. And then there's also like steroid-induced diabetes, which occurs a lot in people who may have other risk factors of type 2 diabetes, but when their body's under a lot of stress and they may be under chemotherapy treatment and then they're taking steroids in addition, and then steroids cause an additional stress on the body, and it can result in diabetes just while taking the steroids sometimes. We also see it a lot after transplants of any type of organ. So the ones I want to focus on, the types I want to focus on are type 1 diabetes, LADA, type 2 diabetes, and MODY. And here's where no one's ever going to remember this chart, but these are really important tests to know to ask about. So as a provider, as a diabetes care and education specialist, I am mortified, for lack of a better word, at how many providers do not try to differentiate the type of diabetes that their patients have. And to me, I'm always like, why wouldn't you want to know? Because you need to figure out the best treatment plan. So the tests are on the left here. So I'm going to go with type 1 first. So in type 1 diabetes, the C-peptide is going to be low. So C-peptide shows how much insulin one is producing. So with type 1 diabetes, sometimes at diagnosis, you'll have a little bit of C-peptide, but eventually you have no C-peptide. So my C-peptide is 0. I make no insulin. Then there's the GAD65 antibody. So that's just showing that you have an autoimmune condition in which your body is attacking your own pancreatic beta cells. So that's going to be positive with type 1. The islet cell, sorry, I almost said insulin. The islet cell antigen is another one of the antibodies present in type 1 or autoimmune diabetes. And then the insulin autoantibodies they're positive in type 1. So LADA is that slower progression type 1 that usually presents in early adulthood, but sometimes at any age adults, just not in children. The C-peptide, so the insulin production is sometimes normal. And that's why LADA often gets misdiagnosed. The other problem is that the GAD antibody is positive eventually, but not always at first. So a lot of these people who have LADA are misdiagnosed with type 2 diabetes. You'll also notice that the islet cell antigen is positive, but the insulin autoantibodies are usually negative. So with type 2 diabetes, none of those antibodies that show the autoimmune reaction are positive. And then with C-peptide, you're either going to be making enough insulin, or sometimes people with type 2 make too much insulin because their body's really struggling, so their pancreas starts producing more insulin to try to get your body to use it. But you usually don't see the low C-peptide or no insulin production with type 2 unless one has had type 2 diabetes for a very, very long time, like years. And then MODY is even more complicated because all of the antibodies are negative because it's not autoimmune, and C-peptide is also normal. So this presents as, wow, somebody has high blood sugars, but we can't figure out why. And a lot of times children are diagnosed with MODY, so then they'll run the genetic testing. There's 12 different types of MODY. So, and some of them are treated slightly differently than others because they all have different defects in the pancreatic beta cells. So based on the type, you may respond actually to an oral agent that's usually used with type 2 diabetes, or you may need insulin. So MODY is important to diagnose as well. So now I'm gonna kind of go into the type 1 diagnoses, and this is because more recently in my own practice and in the type 1 diabetes community, I have heard a lot of stories that there's these younger adults, usually women, that are being misdiagnosed with type 1 diabetes in adulthood. That's kind of what actually interested me in connecting with you guys to do this type of presentation, is all of the misdiagnoses that I was seeing. And I started a conversation about it. But here you'll see in childhood with type 1 diabetes, diabetic ketoacidosis, that critical condition with the fruity breath and the abdominal pain, is pretty common. It presents in 2/3 of cases in children. I was really lucky I was not in DKA. And that's because my mom had some children, I don't know, people older than me might understand this. Google wasn't a thing, and she had some encyclopedia book where she started looking up my symptoms of weight loss and frequent urination, and she literally diagnosed me with diabetes from some encyclopedia that she had. I was really lucky though. A lot of children are critically ill when they're diagnosed with diabetes. The other thing is, for some reason, celiac disease, not other autoimmune diseases, just celiac disease, is very common in children diagnosed with type 1 diabetes, but not when adults are diagnosed with type 1. But then I'm an adult who has both, but I was diagnosed as a kid, so you get that too. But in adulthood, type 1 diabetes there are a lot of misdiagnoses. So part of the problem is that for some reason, and I don't have an answer to this, it was a recent study that actually just came out this month that found this, but those that are diagnosed with type 1 as adults are more likely to be overweight or obese at diagnosis, which makes everything more confusing because those are usually characteristics of people with metabolic syndrome or insulin resistance, which is common in type 2 diabetes. And then what really struck me was that over half of people with type 1 diabetes in this one study were given oral agents instead of insulin at diagnosis. So with type 1 diabetes, you're dependent on insulin. You need insulin because your body's not making any. So if you take an oral agent that reduces insulin resistance, you still don't have insulin. So that's a really big problem, that almost 60% in that study, which it was a large study with thousands of people with type 1. So that was really worrisome. And then that same study and a couple other studies have also found that about 40% or more of type 1 diagnoses are now occurring in adulthood, which is new to healthcare providers. So a lot of the newer trained healthcare providers are aware of this, but not everyone is. And then another characteristic of diabetes diagnosed in adulthood is it's much more likely to be a slow onset, slow destruction of the pancreatic beta cells, which can also be misdiagnosed as type 2 diabetes. So now I'm going to share with you guys a story. So I'm going to share Mila's story. So Mila said she was happy for me to share this with you guys. She is an amazing advocate in the diabetes community. She was the type 2 diabetes advocate. However, turns out she was misdiagnosed. She actually has LADA. She just received that diagnosis, but she's still amazing, an amazing advocate. And I kind of want to share a part of this video with you so that you guys can understand what her experience was like as she was misdiagnosed. So give me 1 second because I have to play the sound from my phone. I've tried to play them at the same time, so bear with me.
Hey guys.
1 second here. Okay.
Mila here. I am the Hangry Woman all over the internet, and today I'm talking to you about a really interesting topic, a hard one to talk about, and also just like not something that I ever expected. But today we're talking about my diabetes misdiagnosis. Now, this isn't something that I ever expected to happen. It's not something that I ever thought was possible for me personally, but it's something that has happened, and here I am. It's been a wild few months kind of discovering this and understanding it and coming to terms with it, but I will walk you through the whole story, start to finish, and I also have some questions.
I'm going to try to get them on the same cycle, so hold on.
I also want to address them.
1 second.
I think some of the questions are just great, and I love that you guys were asking them. So without further ado, let's get started into this crazy story. A few months back, I was having a lot of trouble with my blood sugar, and so I kind of talked about how like my A1C was good and things were working out and things were going well, and then all of a sudden they weren't good at all. Like I went from like a really good like 6.5% A1C up to a 10%, which is a huge jump. And I was diagnosed at 12%. So getting close to like my type 2 diagnosis A1C was really discouraging and disheartening because I was putting in the work. Like I was exercising, I was taking my medications on time, I was taking my medications, I was eating right, I was doing like everything that I thought that I should be doing. And so my doctor said, well, let's test you out over time. Let's kind of see for a period of a few months where your A1C is going to go, what that looks like. And if we don't see any improvement, we'll talk again. And so we go about 6 months. My A1C does not improve at all, even with increased medication. We didn't increase my insulin very much. She kind of kept it steady because she didn't want me taking too much, but then we increased some of my oral medications and tried to compensate in that way. And in doing that and not seeing the results from my A1C, my doctor was kind of like, I am at a point where I think you need to see a specialist because I don't want to keep increasing your medication and I kind of have to tap out here. And that's not how she said it, but like that's pretty much what happened. Is she was like, you know, I want you to go see somebody else because I want to make sure that you get the best care possible, but also what we're doing doesn't make sense. And so maybe somebody else needs to weigh in. So I went to go see an endocrinologist, and he kind of did like the normal new patient thing. He asked me about my entire diabetes history. And so I told him I was diagnosed with type 2 when I was 26. I, got like a pretty good A1C at some point, and then my levels just kept creeping up, and I couldn't figure out why. My primary care doctor couldn't figure out why, and so that's why I'm here. And so he was like, okay, you're diagnosed when you were pretty young, and I was like, yeah, I mean, 26 is youngish, and it was really interesting because my mom was in this appointment with me, so that was kind of cool because she got to like see what an appointment for me was like. And my mom, as you guys know, also has diabetes, so it's cool that we can like have those conversations and go to each other's doctor's appointments and stuff. And I told her, like, I think I just need you for moral support just in case you tell me like something's really weird and out of whack. And so she came with me. I talk about like my family history of diabetes, all of that, and he says, well, I want to test you for something called LADA. Do you know what that is? And I was like, I'm familiar, I've heard of it, but I personally don't think I have LADA. And LADA is latent autoimmune diabetes in adults. So what that means is that your body still potentially produces insulin. So your pancreas will still produce insulin at very low levels, just like any normal person. You just need a little bit of help with like injectable insulins. But then in addition to your body still producing insulin and being in that what they call honeymoon phase, which is where I am now, you also have that immune response where your immune system is attacking your beta cells in your pancreas. And so you're making less and less and less insulin over time. And the insulin that you make is just getting attacked. Like, it's not going to work in your body. So you have to take insulin like by injection, which I already do, but we'll get to that. And that makes it better, helps you regulate your blood glucose, helps you avoid complications from diabetes, and so on and so on. So he tells me about LADA, and I'm like, okay, let's do it. How do I get tested for it? And he tells me it's a simple blood test. And I kind of laughed because I have had friends in the diabetes online community tell me, I heard your story, I listened to what you said, but I don't think you have type 2, and I think you need to ask your doctor for the GAD antibody test. And so I've asked before because I was like, I'm curious, like, I've never had any confirmation of my diabetes diagnosis with type 2, aside from just my A1C being high. I've never had the C-peptide test, which tests your insulin function, and I've never had the GAD antibody tests, which tests your actual like antibody response. So when I asked and I got shut down, I was like, okay, well, I have type 2. I'm overweight. I have a family history of type 2. I check all the boxes. Like, why even worry about it? And it wasn't until I had like that personal experience of like trying so hard to regulate my blood sugar and get it into a good place that I was just so frustrated and so flustered and so upset, because I was like, why am I putting in all this hard work? And why am I spending all of my energy and time and spinning my wheels if this isn't going to work? And finally I had a doctor who, I didn't even ask her, like, can I get tested for this? Like, she was just like, I think that you should go see a specialist because we want to get you to a good place, and, why not get a second opinion about what's going on? So I had been so defeated as a patient over time that I was just like, I don't even want to ask. And I'm so glad that my doctor was like helpful and had the humility to say, like, go somewhere else. Let's send you to someone else. So I get the test done. It's a blood draw. Literally, you like sit in the lab's office, get your blood drawn, takes a minute, and then you're on your way. And then 2 weeks later, I went back. They had me wear a Dexcom Pro so that he could he could see my blood sugars and my patterns while I switched over to a new insulin, because when I told him kind of about like just feeling like things are not working, he was like, let's switch you to a better long-acting insulin to see what happens. So then they monitored me. I went back 2 weeks later to get the monitor taken off and get my results, and I found out that I did have LADA, and I was positive for GAD antibodies and insulin autoantibodies. that was a shock to me. I fully expected for him to say, you were type 2 through and through, that's it, and that would be the end of the conversation, and I would never have to go through the testing again or worry about it or think about it. But instead, he said, you tested positive for antibodies. You are still producing insulin at a low normal level, so your body is still keeping up with insulin production, and you're kind of in a honeymoon phase. And basically that means that my type 2 treatment will kind of stay the same until it doesn't. So there will be a day where I have both the autoantibody response and I'm not ever producing insulin naturally. And so I will be full-time on insulin 24/7, like that will be my life. But I'm in this place called the honeymoon period where, because I still produce insulin, I can still take drugs for type 2, and I'm still mostly being treated as type 2. I'll probably add on short-acting insulin one day. I'm still taking an oral medication called Jardiance, which is so helpful to my blood sugar. It also, I believe, is a kidney protectant. Don't quote me on that, but it helps with kidney function. So your kidneys are protected, because that's a big deal and a big potential complication when you have diabetes. And I can still take all of these things and kind of like work with all of these things. And there will be a day that comes where oral medications won't work, and I will be on insulin full time, and I will be taking more insulin. So it's just this interesting kind of like, I would call it a middle ground, where I have a little bit of both. And so I asked the doctor, I said, what does this mean for?
So I'm going to stop just because I think that was the bulk of what I wanted you to hear. So I kind of wanted to emphasize, though, just kind of like how she felt when her type 2 treatment wasn't working, how she felt defeated and like she was working so hard. And I mean, and she didn't, like, she comes off so sweet and positive and everything, but like she really was defeated. And so it's nice that she's able to share her story about it now, so that we can learn how to increase awareness about this misdiagnosis situation. And the other thing I wanted to point out is that it made me really sad that initially she said her healthcare provider wouldn't test her for the GAD antibodies, and eventually she had a provider that referred her to a specialist to do the test. And I think part of that, part of it is advocating for yourself, but part of it too is sometimes you advocate for yourself and you don't have a provider that matches up with that. And I hate to say be picky with your providers, but you really need to know how to advocate for yourself. And sometimes you have to find a provider that will really listen to you. So I'm going to keep going. I only have a few slides left, and then we're going to kind of have an open discussion. Oh no, how do I go to the next slide? Hold on. Okay. No, 1 second. I think I have to actually go in and change the slide. Technical difficulties here. Okay. So in addition to misdiagnoses, we have missed diagnoses. So in childhood, a lot of times diabetes is mistaken for the flu. I have seen a lot of unfortunate, scary stories about children who are in critical condition, who actually get to the point where they have neurologic deficits and even pass away sometimes from having such high blood sugars and having that those toxic ketones in the bloodstream from DKA. But there are really scary stories about parents who bring their kid to the doctor, who keep saying, hey, there's something wrong with my kid, and they're diagnosed with flu-like symptoms and then end up in this critical condition. So just know that diabetes, type 1 diabetes, quick onset, can present more like a flu sometimes. And then in adulthood, it's also really unfortunate. A lot of the missed diagnoses the diagnosis is missed for years and years and years, and then it only presents, or it's only diagnosed years later when complications present, like kidney disease, heart failure, and then other vascular complications. So those that are at higher risk for having a missed diagnosis and then presenting a diagnosis with complications are those that have had no healthcare encounters in the past year, those that don't have health insurance, of course, goes along with that. Those that don't have any family members with diabetes, because they may not know the signs or symptoms, and they may not be getting screened for diabetes either, since having a family member is a risk factor. And then those ages 20 to 44 are at the highest risk for having missed diabetes diagnoses. And I think that might be, at least in the young adult section, because we don't always go to the doctor or have stable health insurance. But I think another reason is that, the 20 to 44 age range is not an age range in which they're screening for type 2 diabetes. So if they're not screening for type 2 diabetes standardly, they're not going to be screening you for type 1 diabetes either. So I think that falls in that category. And on that note, I kind of just wanted to talk a little bit about diabetes stigma. So there is this stigma. People with type 1 diabetes don't want to be associated with people with type 2 diabetes. I am working to change that. From my clinical experiences, we are all the same. We have different experiences. We may have different risk factors. We may have different diagnosis stories, but we experience the same self-management burden. We need the same type of community and family and friend and healthcare provider support, and we need to navigate insurance and the cost of healthcare together. So we do experience a lot of the same barriers and experience the same type of mental toll it takes. So I think we need to band together and really tackle this. A lot of people with diabetes feel stigmatized, and it's interesting that more people with type 1 feel stigmatized than people with type 2. The one big thing is that people who are heavier, who have higher BMIs, or who aren't meeting goal self-management outcomes have the most stigma. So we are working to change that. So this is one of my last slides here. So here's what I want to leave you guys with. If you think you or a family member or someone close to you needs more testing, number one, talk to your healthcare provider, be your own advocate. We know that doesn't always work. If your healthcare provider isn't open to listening to you, reach out to someone like me. Reach out to someone who knows a healthcare provider that you can connect with that will listen to you. And the best thing to do is to go to someone who's connected to the diabetes community to help you with that. We are here to help you guys with that. And then the second tip I have, connect with the diabetes community. Whether you are the person living with diabetes or you have a family member living with diabetes, there are so many social support resources on the internet that are for not just people living with diabetes, but also their families. And the third tip I have is to educate others and spread awareness, because there are still too many healthcare providers that don't know how to properly diagnose diabetes, and there are too many healthcare providers that miss important signs and symptoms, and you sharing your stories and knowledge will only help spread awareness. So here are some organizations I recommend, mostly online based, except for one of them, for you guys to explore the websites, explore their resources. So Diatribe is amazing. It is the trusted resource. They have everything, all of their information about diabetes verified by healthcare professionals, and they really put out a lot of helpful information about diabetes research, but they translate it to the person that's not in research to understand. They have support resources, and they also have a lot about medications and technology and new things happening in diabetes. And Beyond Type 2 are really special. They are online-based community support organizations. They are across the world. So they have, not only do they have like written resources, they have personal stories. you are more than likely to find a personal story shared on there that matches up with yours, or, you know, one that you really connect with. They also have, you know, all of the diabetes news that's happening, and they also have online communities. They have an app where you can connect to other people, whether you are a caregiver or a friend or a person living with diabetes. And they are actually the first organization to have their own support network dedicated to people with type 2 diabetes. So I think they're really special. And then JDRF is the Juvenile Diabetes Research Foundation. They are more fundraising based to fund a cure for diabetes, but their website has a lot of new information about like the newer therapies and things that are happening and upcoming that can be encouraging and give you hope. So I wanted to leave you with that. Okay, so now I'm going to open the discussion to questions that you guys have. I'm open to anything. Ask away, any diabetes question. I have a variety of experiences, so even if it doesn't directly relate to this, we can still chat about it. So if you want to post the questions maybe in the chat, and then I can just go in order. Let's see.
Julia, while more people may be posting, I just wanted to again thank you for all the information that you have shared and the resources that you're providing. If it's okay with you, I can read the first question that's in the chat, and then for the person, I think Kamisha Rose, who asked the question, if I don't state it, or if there's other things that you need to add to this, please feel free to unmute yourself. But I'll go ahead and ask the first question, which is, how would you recommend advocating for oneself in order to avoid misdiagnosis? Would you recommend getting a second opinion and finding a healthcare advocate for those not as versed in the medical field?
Yeah, absolutely. So I think a lot of times you do need to go to a specialist. So a specialist for diabetes is called an endocrinologist. There's also endocrinology nurse practitioners and PAs and pharmacists. They're called mid-level providers that can do a lot. They can order all the same tests and help diagnose you, just like a physician who specializes in diabetes can. So I would actually recommend going to one of those. And I guarantee, even if you see primary care and you're uncomfortable having the situation with them, there are a few primary care providers that won't give you a referral to endocrinology if you think you need it. So I think a lot of it's just advocating and being open about what your needs are, and just saying, hey, I want a second opinion. I want to go to a specialist. I want some more tests run. And you know, that's kind of out of the scope of primary care sometimes, so they will refer you to endo. You can always get a second opinion. So don't feel like you're doing something wrong by doing that.
Thank you. Much appreciated.
Oh, good. All right, she commented. And then there's two questions I'll combine together from either Andrea and Monica, just stating their lived experience of having family members, relatives, father, grandmother, who passed away and an aunt who passed away that had diabetes. And the questions are really, what do you do if you have a family history? Is there something that you can do as a precaution in terms of getting tested? Hopefully that asks the question correctly. And if not, either of you can comment.
Do you guys have any comments, or you want me to answer? Okay, I'll answer. So with that, so it's, you know, if you're over the age of 45, you should really be getting screened like once a year annually. You should get your A1C or your fasting blood glucose checked, period. But if you have a strong family history, that alone puts you at very high risk of developing type 2 diabetes. So I would honestly just ask your primary care provider to just screen you annually, either a random blood glucose check or an A1C, and just monitor yourself annually, because that'll give you a lot of information about where you are. Now, if you're ever in the pre-diabetes range, definitely focusing on how to eat balanced and how to make sure that you're living like an active enough lifestyle can help prevent type 2 from developing further. So when I talk about eating balanced, the biggest thing is portioning. So reading portions, and then balancing your carbohydrate intake with protein and fiber. Like that is like in one sentence how to balance your food so you can try to prevent type 2 diabetes. You can't always prevent it, but you can, a lot of times it'll have less impact on your blood sugar. Did that answer everything? Yeah.
Okay, the next question is about metformin. Is it still a reliable form of treatment for type 2 given there's so many more new medications? Ruth says she's currently seeing an endocrinologist who feels so many of the new meds have severe side effects. What's your opinion?
Yeah, so metformin is like one of the originals. It's a great medication. It has, the main side effects are GI related. And if you're not getting an upset stomach from it, you're good to go. So it's reliable. It really helps with insulin resistance. It's first line, so most insurance companies make you try metformin before they'll even cover another medication. But I have to disagree. I don't know which endocrinologist you're seeing. Some of the new medications are awesome. There's a newer drug class called GLP-1s, and GLP-1s basically kind of curb your appetite, and they help with insulin resistance, and they stop your liver from releasing so many glucose stores. And they are like cardiovascular protective medications as well. And they help with weight loss, and they're like powerful, amazing drugs. So I don't feel that those have a lot of bad side effects. So I don't know if I agree with the ones that have severe side effects. You'll always see some side effects to some medications. The one that Mila's on, Jardiance, actually has a black box warning about genital infections that can become very severe. But that being said, it's such a rare side effect that it's not like we're not putting people on that medication because of that. So yeah, I think the new medications are still great. But metformin is still great as well. And actually a lot of people with type 1 take metformin off label to help with insulin resistance. Like people who have type 1 sometimes develop insulin resistance too, and they'll take metformin. And yeah, so.
What is an example of a GLP-1?
Ozempic, Victoza, Rybelsus, Trulicity. I actually think that's all of them.
What were the other two? I have Ozempic, Trulicity.
Victoza. And Rybelsus. Rybelsus is an oral medication, and the other three you actually inject.
What's your favorite?
Ozempic.
Okay.
It's the best with weight loss, and it's the best with A1C reduction. And the only problem is it's expensive, but if you can get insurance to cover it, it's good. That drug class insurance doesn't like to cover because it's expensive, but we're seeing really great outcomes. The only side effect we see with it is a little bit of GI upset at first, but it's not like metformin where some people never are able to tolerate it. And then the other thing is if you have a history of pancreatitis, you may develop more pancreatic irritation, for lack of a better explanation. But that's really the only thing with it. So.
Thank you.
Yep.
So we have a couple more questions. The first is regarding the insulin pump. Is there a frequency of how often it should be changed, and what are concept of hygiene in relation to the pump? That's from Monet.
Yeah, so insulin pumps are little devices that basically house enough insulin for 3 days. And the insulin goes through tubing, or sometimes it's on a patch pump and just goes through a little plastic cannula that's under the skin, but even when it's delivered through the tubing, it still enters the body through a little plastic cannula. Actually, I'm conveniently sitting in front of my pump stuff. So I will show you. So like this is what the big thing looks like that you insert into the anywhere where you have fat, usually your abdomen though, your buttock, your thighs or your arm. And I'll just like pull it off so I can show you what the cannula looks like here. So basically a little needle, it doesn't look small, but it is, injects and then retracts and leaves this little cannula under your skin. Cannula looks like this. It's like really tiny, and that's where the insulin goes through. And because you're injecting this into your body, and there's medication going through here constantly, you have to change it every 3 days. So you change the tubing part and the infusion set every 3 days, and then it connects to the pump, which I conveniently have a demo pump right here in the store. You basically tie the tubing together. This is the pump. And then there's, in the back here is where you store the insulin. This also is changed every 3 days. So you just change the insulin, the tubing, and the little needle that inserts the cannula every 3 days. I think it's a lot to adjust to at first, but people that do it do really well on pumps usually. And with the right like training, support, and education, someone who takes time with you and doesn't make you feel overwhelmed, you can do really well with them. The only thing you have to do to your skin though is like clean it off with an alcohol swab and you're good. So any other questions about that? No.
No. The next question is from Nia, just stating that awareness of disparities in healthcare for Black women has increased. Is there any research exploring how these disparities might affect the likelihood of misdiagnosis or misdiagnosis for Black women?
No, but that's my next project. I'm not joking. I don't know if you guys know my friend Siobhan Aaron, but she's actually the mutual friend that connected me with Kalila about this. But we're both we both have PhDs in nursing, and she's interested in healthcare disparities. I'm interested in diabetes. And one thing we talk about a lot is what I'm seeing clinically. I can tell you, I see a lot of people that are misdiagnosed with type 2 diabetes at first, but they really have type 1. And at least half the time it happens in Black women. That being said, what really struck me though, like what really was the final straw for me for wanting to do a project that's not necessarily related to my young adult financial stress that makes me want to explore this further, is I now know 5 young adult Black women in the diabetes community who are diagnosed with type 2 diabetes and actually have type 1. And just hearing their stories and just the psychological impact that has really has struck me. So there's not research on it, but I want to do research on it.
And I would just add to that, I see a lot of people nodding or shaking their heads. So thank you for bringing that to light, and hopefully more and more will start to come out about it and more research can be done in that area to make improvements. Was there another question, or Nia, did that answer your question?
Yes, it did. I look forward to seeing what you come up with.
Okay. The next question again is about metformin. Is it still good to use if you're pre-diabetic? And then there's only one other question after that.
Yeah, so metformin's actually totally cool. Totally safe to go on if you have prediabetes, because what metformin does is it stops your liver from releasing so much glucose storage, basically. So it reduces the amount of glucose you have in your bloodstream. So when you have prediabetes, you actually already have a little bit of like that metabolic dysregulation and a little bit of insulin resistance. So going on something like metformin will help your body have less of that extra glucose in the bloodstream, even though you only have a little bit of it. And it will prevent your body from becoming more stressed. So a lot of times we put people with prediabetes on metformin, and especially people that are at high risk of developing type 2. And yeah, and it helps.
Okay. So from Tarika, it says, we know that type 1 and type 2 diabetes are very well known. Why is it that diabetes like LADA and MODI are not really pushed education-wise in the community, and how can we get that information and resources out there?
Yeah, so I think the main issue is that LADA is becoming more common. We don't know why it's becoming more common, but it is. And well, and we sort of know why. I think part of the reason why is because more adults in general are being diagnosed with autoimmune diabetes now. 20 years ago, I think only like 10 to 20% of the type 1 diagnoses were in adults, and now we're at like 40%. So I don't know why, because I don't think we really understand why, but when adults are diagnosed with autoimmune diabetes, it's more likely to be LADA, like the slower autoimmune destruction of the pancreatic beta cells. And I think because it's a newer phenomena, healthcare providers aren't as aware of it. And I think with MODI, it's not common. And because it's not common, healthcare providers aren't aware of it. That doesn't mean you shouldn't be aware of those, though. I mean, LADA, especially if they're saying most adults have LADA, if they're diagnosed with type 1, we really need to know about it. MODI usually only really specialized endocrinologists will even test for it, because usually they figure out a treatment plan that works without the testing. So that's kind of that.
Thank you. This was just a comment, I think, going back to the question around Black women and misdiagnosis is, I wonder if it's in relation to, due to the stigma or stereotype of unhealthy lifestyles of Black individuals.
Yeah,
I
think we don't know any information. So one of the first things we have to do is explore the experiences surrounding it to kind of figure out more of what's going on. I think healthcare providers that, I think some healthcare providers probably assume that, but that's not what they should be doing. So.
Thank you. And then another question is, what exactly is a diabetic coma?
Okay. So diabetic coma. So it happens when your blood sugar is really, really high. Like really high, to the point where you start having neurological complications from it, because your body is just completely stressed and you don't have the energy stores. It's pretty rare.
Those are all the questions in the chat. In the last moments that we have remaining, did anybody want to ask a question outside of the chat, or come off of mute to ask a question or make a comment?
I have a quick question.
Sure.
So regarding the diabetic coma, can it not occur during lower blood sugar levels? Is it only when it's high?
Yeah, so the term diabetic coma is usually in relation to very, very high blood sugars. However, you can have hypoglycemic seizures, and that's what happens when your body doesn't have any energy, but in a way that is different than when you have too much glucose that you can't process. And so, but most times, I hate to say this because it makes me so sad, but most times with low blood sugars, if you go into a coma, it's because you have severe neurological impacts, and and a lot of people die that way. So I think you're more likely to experience like a high blood sugar diabetic coma and come out of it than a low one.
Thank you.
Any other questions or comments? I have one that I think it wasn't asked explicitly, but I would just ask you, how do you suggest people advocate? The healthcare system we know is complex. Maybe your primary care provider diagnoses you, but you may not know what an endocrinologist is. What does advocacy really look like for someone who has no medical background, maybe no family in healthcare?
Yeah, so I mean, advocacy starts with you as a person educating others, right? And kind of raising awareness about what's going on. So you don't have to be a healthcare provider to be an advocate. There's a lot of patient advocates. Patient advocates and caretaker advocates are the best advocates, actually. But it's people who are really sharing the experiences and sharing knowledge about what it's like to live with certain conditions, and that raise awareness of the issues to educate the people, kind of like, you know, like the endocrinologists that are the ones, for lack of a better term, in charge in some way of diabetes, to make a difference, right? So the more people that speak up together and share their stories about misdiagnoses, the more the community is going to start hearing it. So one way to get involved, if you go to Beyond Type 1, you can share your own story. So sharing your own story with others through one of these organizations is a really good way to get involved in advocacy. Another thing you can do through JDRF, they have programs where you can be a diabetes mentor and connect with other families of diabetes, and just connecting with others and sharing your stories and getting involved in the nonprofits that focus on support for diabetes, and, you know, getting involved in projects through those nonprofits, getting on their email listservs to see what you can do to help is another great thing you can do.
I need to make some decision on this thing with the
Siobhan, did you have a question?
Yes, I had a question. Well, it's kind of like a comment. So thank you, Julia and Kalia, for putting this together. I just love this webinar. It was so informative. But I wanted to say for advocacy, because I heard a few questions about advocacy. And one story that resonated with me was a patient who asked a question and felt like she wasn't getting answers. And she said, I have a right to ask questions about my healthcare. And so even me, as a nurse, I've been to specialists and they were like, oh no, that's for me to worry about. But I ask questions until I get an understanding, even if it's a subject that I don't understand much, but I will keep asking questions. And that comment really resonated with me. I have a right to ask about my healthcare. And if something doesn't seem right, a lot of times it probably isn't. So I would say advocacy is understanding and ensuring you get the proper questions. And if you have a provider where questions are not answered, I would say seek further opinions. You have ombudsman, you have nurses, you have other providers.
Yeah, asking questions to understand so that you can then educate others and support others is like key self-advocacy skills. So it's really important.
I keep putting myself on mute. But thank you both. I like the statement that I have a right to ask questions, or I have a right. And I think that's a big takeaway, as well as all the other information that was shared, is that we all have rights when we are receiving care in the healthcare delivery system. So thank you.
Yeah. And I think, Siobhan, I think because I'm an advocate, sometimes I don't know how to describe how to be an advocate, because, you know, like, I've done this my whole life. I've asked questions. I've questioned the doctors. I've told the doctors what I think they should do based on this, this, and this that I discovered online, or this research study that I found. And that's kind of how I ended up being who I am, right? But I think sometimes when you do it, you don't know how to explain it. So thank you for that statement, because that's a really powerful.
Thank you. Yeah, it really resonated with me when I heard that statement. Thank you.
Yeah.
Okay. Well, if there's no more questions, again, we thank you, Dr. Blanchette, for your presentation today. We have recorded it, so we hope that we try to post our videos on our YouTube site. But you'll also receive an evaluation after this, and we just ask that you take the time to complete it. And I hope everybody enjoys the rest of their evening. Thank you.
Thanks so much
Thank
for
you so
having me, for
much.
giving me this opportunity to talk to you guys, and happy Diabetes Awareness Month.
Thank you